Uh, Welcome everybody to today's session. Today's session is on hypertension. So hypertension may be seen with primary disorders in the ICU or may be associated with certain situations. So talking on that will be Dr. Jitendra Sharma. He is Chief of Critical Care at Artemis Hospital, Gurgaon. And after that, we'll have a short session on antihypertensive drugs. That will be taken by Dr. Neha Sharma. She's Neha Arora. She's a critical care consultant at Paras Hospital, Gurgaon. So over to you, Dr. Jinderson.
Thank you, Dr. Tapesh, for kind introduction. Dr. Tapesh, you just...
Yeah, I will just, 1 minute.
So good evening, friends. Today we'll discuss one of the relevant topic to us is the hypertensive crisis. Slide is visible?
Yes, slide is visible.
So we'll start with our relevance with this topic. So after completion of this class, so what questions comes in our mind? Can I work up most of the patients of hypertensive emergencies and urgency? Can I assess the severity of hypertension? Can I assess for hypertension mediated organ damage? That is the HMOD. Can I make strategy for initial management of hypertensive crisis of various conditions? Can I select drugs appropriately for hypertension crisis? So answer to all this question would be yes. Of course, we'll answer all these questions. Another set of questions, can I work up all hypertensive patients? Can I diagnose etiopathogenesis of all hypertensive patients? Can I manage mild hypertension? Can I make strategies to manage mild hypertension and chronic hypertension? Will I know all medication used to manage hypertension, including oral drugs? So I really apologize. Can I follow up all hypertensive patients? So I apologize. The answer to all questions would be no. We'll not discuss information related to these questions. So what would be our objective of this talk? I'll divide this talk into the initial examples and clinical scenarios, pathophysiology of the hypertension, etiologies of common hypertensive crisis, which is relevant to the acute care and the critical care, clinical presentation in ICU, management strategies of the hypertensive crisis, hypertension in specific situations, and lastly, summary for the management of the hypertensive crisis. In between, you will have a few MCQs also. So I expect your active participation for that. So start with the examples. So let's see some clinical scenarios. A 56 years old male with no significant past medical history presented to the ER with headache, found to have blood pressure 210 by 110 millimeter mercury and papilledema. In another case scenario, an 82 years old male with history of hypertension and CKD presents for a routine physical examination and found to have a blood pressure of 230 by 130. A 76 years old female is brought to the ER by the family due to altered mental status. BP is 240 by 110 mmHg with no focal neurological findings. So most of these clinical situations we come across in ICU. So typical examples which will really deal the situation is like asymptomatic old age blood pressure to the tune of the 200 by 115, 143 mean arterial pressure, embolic CVA with BP 215 by 105, Hemorrhagic CVA, again with hypertensive crisis or severe hypertension. Subarachnoid hemorrhage with the blood pressure 180 by 100. Aortic dissection with the severe hypertension. Pregnant female with the blood pressure 150 by 100 mmHg. Encephalopathy with severe hypertension. Acute pulmonary edema with the severe hypertension. So few definitions we also use, and a lot of literature is also using, and these definition is also used for the experiment and the trial purposes also. So just to understand different terminology, hypertensive crisis is the broad term. So under this we can divide into the hypertensive emergency, that is a hypertensive crisis with the severe hypertension. The numbers they made it is the 180 by 120 mmHg with acute impairment of an organ system, could be a CNS, CVS, renal, which is known as a hypertension mediated organ damage, HMOD. Another definition which is usually should be avoided anyhow, but it is extensively used. Even it is used in the various guidelines for the hypertension, like European guidelines. That is the malignant hypertension. This is the syndrome in which uncontrolled hypertension directly causes organ dysfunction, including retinopathy, and papilledema should be present. So most of definition you will not find a much difference between hypertensive emergency and malignant hypertension. Of course, the distinctively a papilledema is mentioned. Over the years and study of the profile of the different patient, papillary edema doesn't make a much difference when it comes to the clinical management. So in ours, subsequently, we take these things almost interchangeably, hypertensive emergency and the malignant hypertension. Hypertensive urgency, the increased blood pressure. In this situation, it is a potential risk, but not yet cause the hypertension mediated organ damage. Accelerated hypertension is also a word which actually denotes the recent significant increased BP over baseline that is associated with the target organ damage. This is usually vascular damage on fundoscopy examination, such as flame-shaped hemorrhages or soft exudates, but without papillary edema. So in our initially the case scenarios, like a 56-year-old male with the headache and the blood pressure, severe hypertension and papillary edema, so almost corroborative with the definition of the malignant hypertension. Elderly male, hypertensive, already known chronic renal disease, for the routine physical examination found to have a blood pressure, you can label it as an accelerated hypertension. 76-year-old female, which is brought to the ER by family due to the altered mental status. So technically the neurological symptom is there. So we can label it as a hypertensive emergency or hypertensive encephalopathy. This is a tabulated form to denotes the severity of the hypertension according to the grades. In our intensive care, we are more concerned with the grade 3 hypertension, which we are talking about in our subsequent talk. So that was our set of examples, and we set the base of our discussion. We are not discussing the recently diagnosed blood pressure or the mild blood pressure or the chronic blood pressure management. These were the few examples which we have talked about. Now we move on to the pathophysiology, which again relevant to us. I'll keep the discussion brief, which is relevant to us while we manage the patient. So most is the clinical relevance. This is a very important slide to understand. Usually there is a balance between the vasodilatation and the vasoconstriction. In hypertension, so there is a release of the mediators in the form of norepinephrine, angiotensin, endothelin, thromboxane, vasopressin. These are the endogenous, not the exogenous, which we are talking about. So endogenous vasoconstriction is happening at the organ level. So vasoconstriction happens. This also causes a platelet activation and thrombin formation happens. On one side, there is decrease in the diameter of the vessel, and the second is the platelet aggregation. Both combination results into the microclot formation, and overall pressure gradient is more than the surrounding intraluminal pressure is more, and the outside of the vessel is pressure is less. Already endothelial damage has happened, so water come out, edema is there, and the fibrinoid necrosis, leakage of protein into vessel wall leading to the thrombosis and ischemia. In this way, the spiral pathophysiology happens. This is I'm talking about the at the organ level. It is a common for the CNS, common for the retinopathy, common for the nephropathy. All the manifestation which we are will subsequently discuss about the hypertensive mediated end organ damage. This is the common pathophysiology over there. We'll little bit pay more attention to what exactly happened and why it is happening. So one is the auto-regulation, which is all the organ is having. When I using the word here auto-regulation, it is not necessarily confined to the brain only. Every organ is having some form of auto-regulation in terms of the a perfusion to that organ. So when there is a rise in blood pressure, arterial and arteriolar constriction happens. I'm not talking about the SVR happening that result into the blood pressure. This point is actually effect of the blood pressure at the level of the end organ. So blood pressure increases first and the vasoconstrictions happens in response to the blood pressure. That eventually keep the flow normal. Just to remember, this formula, flow is equal to pressure divided by the radius of the conduit. So if pressure would increase, then definitely flow would be increased, and eventually all the organ will have a hyperemia. That is the detrimental to the organ. In fact, it is a preventive homeostasis of the body in the form of autoregulation. Vasoconstriction happens. So denominator is less than the pressure, and all these things keep the blood flow normal. Autoregulation failure, rise in blood pressure, failure of vasoconstriction, and endothelial damages happen due to shear stress on the wall. So this fail in autoregulation lead to the organ damage, which we can see over here. If blood pressure increases, initial vasodilatation happens to accommodate the ischemic part, and the subsequent increase in the blood pressure will not allow to the increase in the flow, and with the beyond the autoregulation, then there is a hyperemia because of the flow is also increased over there because of the damage. Chronic hypertension, because what we are discussing here is the combination, I will not say combination, distinct pathophysiology. One hand, there is already blood pressure high over the so many days to years, and second is the sudden rise of the blood pressure. When blood pressure remain high for the so many days to years, this autoregulation is shifted towards the right. So the same blood pressure which is a higher for the otherwise normal, if it has happened suddenly over there, it will produce the hyperemia and the injury, but these chronic hypertension will not have. And beyond certain point, there would be a increase. So that is the pathophysiology, and this autoregulation curve, though we talk about all the time related to the brain only, but it holds true for the every organ. Every organ will have a such type of autoregulation curve. Now, etiology of the common hypertensive crisis which we see in our clinical practice. One, in the form of essential hypertension, that is the underlying hypertension, and the second is the secondary hypertension. Secondary hypertension further divided into the different categories. One category is renovascular diseases like atherosclerosis, thrombosis, fibromuscular dysplasia, medium and large vessel vasculitis. Glomerular diseases, glomerulonephritis, small vessels vasculitis, microangiopathies, scleroderma, renal parenchymal diseases like polycystic kidneys and the other renal parenchymal disease, renin producing tumors, endocrine causes, pheochromocytoma, primary hyperaldosteronism, Cushing syndrome, hypercalcemia, and certain uh, a secondary effect of the other pathophysiology is like aortic coarctation, that is a pressure gradient, and then finally it causes the high blood pressure. Medications like a cyclosporin, tacrolimus, erythropoietin, which is commonly used as an immunosuppressive agent for after the solid organ transplant. And the sympathomimetic drugs, among this cocaine is a one of the commonly seen certain areas where the cocaine consumption is high, and you can really see a hypertensive crisis in this patient. Amphetamine is the another sympathomimetic drug. So till now we understood the examples, pathophysiology and the etiology. So there is a question related to the this segment of talk. A 56-year-old received a kidney transplant and started on a variety of chemotherapeutic drugs. 4 years later, he will be prone to developing hypertension, lymphoma, nephropathy, gastritis.
So please put your response in the chat box.
This appears to be very simple, straightforward question, but we expect the participation from the audience so that it would
Answer is A.
Answer is, I got a answer in the chat box. So hypertension. Why? Because most of these patients require a tacrolimus as immunosuppressive agent, and this is the one of the common cause after the solid organ transplant. Another question: what diagnosis would be considered in a patient experiencing hypertension, palpitations, and headache during their first trimester of pregnancy? This is a little bit tricky. Eclampsia, anxiety, CMV infection, pheochromocytoma. Any response?
No response so far.
So here is the pheochromocytoma. The important key factor while solving this question is this is during first trimester of pregnancy. So gestational hypertension or the eclampsia, these happens after the 20 weeks of the pregnancy. Another pre-existing hypertension can happen, but among all these choices, the best fitted would be pheochromocytoma. Anxiety can lead to a little bit of kind of this thing is, but can't really having a very high blood pressure along with the headache. Now we move on to the clinical presentation in ICU setting or acute care setting. The important here, few things will not able to understand clearly. These clinical things happens because of the hypertension, or these pathophysiology, all the clinical manifestation already existing that lead to the hypertension. So both these things, or the certain clinical manifestation we'll discuss. So here like egg and chicken kind of a discussion, whether the kidney damage happens because of hypertension or the kidney disease is there, therefore it lead to the hypertension. Such type of the problem and complex pathophysiology remain in the clinical practice, and there will be no conclusive answer. But this is important slide for our acute caregiver, so that they can quickly see the clinical manifestation and association. So I will use the word association. sometime may not be a directly, like a stroke, cerebral infarction, cerebral hemorrhage, subarachnoid hemorrhage, that may be a probably primary problem and lead to the stroke. And sometimes hypertension can lead to the pre-existing problem with the vasculature anomaly in the CNS, and that lead to the SH. Retinopathy, obviously, we talk about the grade 3 and grade 4. We'll discuss a little bit about the retinopathy. Aortic dissection, you can have a tearing chest or back pain. Arm leg BP would be different. Absent peripheral pulses. Angina with myocardial infarction can happen due to increase in the LV afterload, increased wall stress, and decreased diastolic myocardial perfusion. So again, this would be a little bit complex. MI happens, and therefore the blood pressure increase in the response to the MI as a stress phenomenon, or the hypertension first happens, and that lead to the stress and the myocardial insufficiency. Whatever happens, and all these things eventually that lead to the hampering on the both side. More the problem will happen, the more blood pressure increase, and that will cause the eventually a myocardial infarction. Based upon that, we'll discuss the timeline how to really respond in this situation. Pregnancy related pre-eclampsia and eclampsia, we already mentioned about that. We'll discuss a little bit in the detail. Encephalopathy, one can see this is typically cerebral edema secondary to the decreased CNS vasculature autoregulation. If you remember in the initial talk, I showed you two important illustration. One is the autoregulation, and second is failure of vasoconstriction lead to the vasodilatation and the hyperemia. And before that, there is a edema and the leaking from the vasculature. That is the primary pathophysiology in the encephalopathy. Now most of the people use a hypertensive encephalopathy. Sometimes it is labeled as a press also. For us, as a acute caregiver and the critical caregiver, will manage both the things in a same way and almost a similar pathophysiology, or maybe a same pathophysiology. So you will see the patient complaining of the headache, nausea, vomiting, blurred vision, confusion, and later on the focal neurological deficit, seizures, papillary edema, and coma. Pulmonary edema or heart failure, again, this is a manifestation of the hypertension, as well as the initially hypertension is happening, and that lead to the pulmonary edema and all these things. This is a example of the chicken and egg kind of a theory. Progressive renal impairment, you can see increase urea creatinine, decrease GFR, hematuria, proteinuria. Hypertension may also be secondary to the glomerulonephritis and renal artery stenosis. So these areas are more or less little bit complex. Either it can cause the hypertension, and it is the result of the hypertension. Retinopathy, though intensivist is not really put more stress on the retinopathy, because is not usually they see the fundus. I request everybody to at least start seeing the fundus. Sometimes they are the very clear cut a science would be in the retinopathy, and the technology evolving now will have a more easy equipment to see the fundus directly on your phone screen or even on your computer screen. So it's no more kind of a subjective, though it is believed to be a subjective initially. The retinopathy, obviously, subsequent slide will give you a demonstration of, will give you a grading of the retinopathy. But technically, two important things. One is like ischemia is happening. When ischemia is happening, that causes a hard exudate. And when hyperemia is happening, when the rupture in the fluid is coming out over there, that is the cotton wool spots are there. So same pathophysiology, initial vasoconstriction, then exudation, and finally hyperemia. That happens in the brain, that happens in the kidney, that also happens in the retinal vessels. But retinal vessels are smaller one. They can be easily kind of manifest what is happening. Therefore, we use the fundus examination to assess the severity of the retinopathy. Obviously, 0 to 2 stage, mostly will not able to see it. Whether you want to remember for your exam purposes, obviously you can remember. But last stage 3 and stage 4, this is not only your exam, you can easily, once you start seeing after 5 or 10 images of these manifestations, once you see, then your mind would register and you'll hardly make any error regarding recognition of the retinal hemorrhage, hard exudate edema, and optic swelling. Similarly, nephropathy and microangiopathy principle will remain same. The hypertensive emergency that result into the malignant nephrosclerosis is the term which uses when it is associated with the hypertension. Fibrinoid necrosis happens, hyperplastic arteriolitis happens, neutrophilic infiltrations, and thrombosis of glomerular capillaries. So when you take a piece and histopathological examination, exactly the similar finding will you find which happens with the hemolytic uremic syndrome or thrombotic thrombocytopenic purpura. So it's not only your renal biopsy give you answer for the diagnosis, the clinical context is very important. Your hypertensive nephropathy will also give a same appearance which happens with the HUS and the TTP. The malignant hypertension, which have a typical clinical features of microangiopathy, including thrombocytopenia, elevated lactate dehydrogenases, and cystocytes on blood smear. Why it is happen? Again, we make a medicine so easy. Whatever derangement we see in the blood, we label it as a hematological disease. This is not the hematological disease. This is the purely a cardiovascular disease. The manifestation is happening, and the cystocytes is coming because of the microangiopathy. There is a destruction of the RBC because of the narrowing of the capillary and the small blood vessels, which lead to the cystocytes. So people make so much simplification of the, if cystocytes presents, then the possibility TTP. And TTP is there, they take a therapeutic decision based upon that, and they started doing the therapeutic plasma exchange. When in this situation, it is of no use. You have to treat the underlying problem. Earliest evidence of renal involvement in the presence of abnormal urine sediment with proteinuria, hematuria, and appearance of the red and white blood cell cast. It is more relevant in the, you can say, not the severe hypertension or the early part of the pathophysiology, the nephropathy. Probably pulse intensivist may not be really make any diagnosis based upon these findings in the urine. So that was all about the clinical presentation. Till now, we have discussed the pathophysiology, we discussed the etiology, we discussed the clinical presentations in the form of the different organs involvement. Now, management strategies, we move on to the management. Management principle. Step 1, confirm that blood pressure elevation is truly severe. I'll not go into the detail. There is a certain problems with the blood pressure measurement. So you have to be really very clear about the blood pressure reading of the particular patient. Step 2, say for example, in invasive pressure monitoring kind of this things. If your transducer is very low from your phlebostatic axis, it will erroneously give you a blood pressure high, and you start taking the decision based upon that. So this is just one example. What I mean to say, step 1 is the confirm that blood pressure elevation is truly severe. Second, step 2, look for clinical feature of threatened or actual end organ damage. So in clinical feature, we discussed the how you can really know the end organ damage based upon the clinical finding, complaint, as well as the physical examination, and the retina is one of the part for that. Step 3 is the detect and manage triggering factors. For example, which we usually say is the general manage general measures for that. Say for example, pain is a triggering factor, then give the analgesia rather than treating the hypertension. Anxiety and stress, give the anxiolytics. Delirium sometimes can cause a blood pressure very high in the in ICU. And sometimes at times it would be a little bit different to differentiate whether the patient is having a hypertensive encephalopathy or a delirium causing the high blood pressure. So these are the clinical nuances where the experienced ICU physician, the physician can easily make out the difference between the delirium causing the hypertension or hypertensive encephalopathy. And of course, the delirium causing the hypertension requires the antipsychotic. Sometimes drug withdrawal, so we have to treat accordingly. Urinary retention sometimes can lead to a very high blood pressure. You just put the a catheter in the bladder and the things would settle. Hypoxia, hypercarbia, that can also a reactionary blood pressure, then you have to treat it. Hypoglycemia, sometimes the initial phase of hypoglycemia, that triggered the sympathetic activity and blood pressure. So you manage these things in general. If hypertensive persists, then consider antihypertensive to reduce blood pressure to desired range in gradual manner. So here this little bit of keyword are there, desired range and gradual manner. We'll discuss subsequently. Hypertensive emergency, which is not specified in other specific condition, which we label it as a malignant hypertension also. So how to manage the malignant hypertension, where the no any other specific hypertensive emergencies we are talking about. Like initially we have seen the high blood pressure associated with the pregnancy, high blood pressure associated with the pulmonary edema, high blood pressure associated with the SH. This is not the things which I'm talking about. This is a hypertension per se, not really associated with any specific condition. So the principle is obviously shift of autoregulation curve. This is the basic pathophysiology happens. And application of this knowledge, rapid reduction in blood pressure may cause organ ischemia. So you have to keep this thing in mind. BP must be reduced immediately with initial goal of no more than 15% reduction. So when there is a hypertensive emergency, obviously we keep the autoregulation concept in our mind. That doesn't mean we will not start treating it. We have to start to treat it, but obviously in the more gradual manner. And we have to fix the certain numbers. That is a 50% reduction. In clinical practice, we will not maybe a 15%, maybe a 17, 18%, maybe a 10%. But somewhere you should not reduce to the tune of the 30, 40, 50%. That is the essence to make this statement. In hypertensive urgency, oral medication over the course of several days. So that is the principle. In urgency, we really don't require the intravenous infusion, which people also use just to treat the number. This is all the guidelines, and in really in clinical practice, obviously these should be corrected with the oral agent over the days. Specific treatment goals should be individualized to ensure that the pressure is reduced sufficiently for organ failure to resolve without compromise perfusion. This is important statement. One hand, you have to reduce the blood pressure because you can't keep it high all the time. Eventually, it will lead to the end organ damage and maybe later on irreversible. But simultaneously, you have to keep the track and should not compromise the perfusion. The way you decrease the blood pressure, if it is beyond certain rapidity or more rapid, that it may compromise the perfusion also. So both the spectrum organ will be at risk. So it's your responsibility how to manage it. So that was a basic management strategies. Now we reach to the last segment of our talk. Very, very important. Till now we discussed all the basic principle and all these things. This segment of talk is directly application of the knowledge in the clinical practice immediately over there without much alteration. So therefore, just keep attention for this segment. In this, we'll discuss neurological hypertensive emergencies like ischemic stroke, intracranial hemorrhage, subarachnoid hemorrhage, posterior reversible encephalopathy syndrome, commonly known as PRES, cardiovascular hypertensive emergencies like acute coronary syndrome, acute heart failure, aortic dissection, pregnancy-induced hypertension, and lastly, a perioperative hypertension. Uh, this is just a typing mistake. Preeclampsia and eclampsia is a part of pregnancy-induced hypertension. The perioperative hypertension is the separate last condition. I apologize for that. So first, neurological hypertensive emergencies like ischemic stroke. What are the principle over there? And lastly, we'll discuss the timeline and how much and the one or two drug. The here principle one is we need to understand a little bit stroke. Why? What is the problem and what is the important thing is whenever ischemic stroke happens, there is a central ischemic core area is there, which is infarcted, and significantly, sometime significant proportion higher than the original infarcted area is having a penumbra area where there is a risk for this reversible tissue damage to permanent tissue. That is very, very important fact for the ischemic stroke. And whosoever either perfuse it or at least don't harm it further. This is the basic principle over there. If once you understand, then obviously you will not have a what I will say immediate urge to treat the number. You feel you are treating the patient, eventually you are harming the patient. So what is important essence here is anything which is helping to perfuse this area, then definitely we'll do that. And if you can't do that, then at least don't do something which can harm or which can further reduce this perfusion. This will discuss. And obviously, the auto-regulation affected over here. And this situation, I'll not going the detail of all these things, but as a physician and an intensive care physician, all the time you keep your mind aligned with the what is the context of the hypertension. Is it really over the years hypertension happening and now lead to the severe hypertension? It is having a little bit different and different principle for the management, or somebody consumed the cocaine and came with the hypertension, though both the patient is having a 220 by 110 and that patient is also having 210, but their pathophysiology and the underlying vasculature differ in drastically. So this hypertension, when the sudden happens, then auto-regulation curve is not really shifted. But here, these are the chronic hypertension or hypertension mediated injuries to the blood vessels, which we also discuss subsequently, that causing it, and it is having a principle over there. So you have to keep the auto-regulation principle in your mind when you are treating the blood pressure in ischemic stroke. When I say in your mind, that means you have to see whether you really want to treat the high blood pressure or not. So if you don't manage this area, so over the time period, the necrosis here, you can see just overlapping on the CT scan to understand. This is the red zone and the orange and the finally green. And eventually, if you don't manage it properly, then you lead eventually that progress to the larger infarcted area. That things keep all the time in your mind, not just the number of blood pressure. Why I'm saying you this is, do not reduce the blood pressure if it is less than 220 to 120. Though the common man, not only common man, even the other doctor also who is having a 180 by 100 blood pressure, they wanted to treat it because all the time they say the blood pressure ये दवाई गोली लेते नहीं थे इसलिए problem हो गया, now it will cause a further damage. So now अब acute emergency, now the family feel this time at least you should reduce the blood pressure. Technically you are doing harm than the benefit over there when you are not thrombolysis. So as I told you in the initial slide, if you are doing something to reperfuse, then it has priority over there. So if you are planning for reperfusion of that area, then definitely reduce it, because once you administer the thrombolytic agent, then it may cause the hemorrhagic complication with the high blood pressure. So here I hope everybody is clear about this. One hand you are saying do not reduce the autoregulation happening. Now when you are giving the thrombolysis, the autoregulation, the concept will not be applicable. Definitely it will be applicable, but the priority is changing. Now you are doing something which is actually perfusing that penumbra area, and previous condition when you are not planning for the thrombolysis, you are not perfusing that area. But now if you reduce the blood pressure, you allow the infect area to grow further. That is the basically bottom line of the this segment. Commonly this error happens in ICU. People start treating the blood pressure. So when it crosses the 220 by 120, then only you start treating with the antihypertensive agent. How to reduce it? Don't get confused. When you decided reduction more than 220, or when you are planning for the thrombolysis, then only this will be applicable. When you decide it is really reduction is required, then reduce 15%, so a little bit difference, reduce by 15% over 1 to 2 hours, and monitor closely for neurological deterioration. Sometime, because the numbers are the simple things to express in the books and the literature in the guidelines, but every patient may behave differently. Whatever you are thinking 15%, they may be too much for him also, for this 15%. So you have to keep this thing in mind. This segment is clear to everybody. Now we are moving to the another stroke, that is the intracranial bleed. It is having a little bit a different understanding over here. So these two are important. Then the subsequently will discuss a little bit faster over here. One thing, what happens? Why the blood pressure when high, that causes the bleeding, and that too a very specific. People, you must be aware of the hypertensive bleeds is having a characteristic locations. Why it is happening? Why so much selectiveness over there? Because of the structure over there. So here more you can say your biology and physics comes into the play. Those arteries which is having a right angle division from the main stem, they will have a more burden of the problem. If suppose this is having an acute angle over there, then there is no problem. That's why the nature has given. Have you seen the so many blood vessels actually divide in the acute angle, not really right angle over there. Most of the blood vessels you see internal iliac, and then further divide into the right iliac and the left iliac, then internal and external, all are in the acute angle. When it is a right angle, then so much pressure is actually happening, and that confluent area over there, all the time this pressure actually replaces endothelial injury happens, and this endothelial and the fibrinoid proliferation, lipid deposition, and finally it becomes a collagen a material, and smooth muscle is actually replaced over there. Over the days, years, every minute, every stroke of blood pressure is coming. You see in the rivers and all these things, long rocks converted into the rounded stone. So much flow is happening all the time. So gradually this water is having so much tendency to convert into the round stone. So this is the called of, you can say, a rheological property, or something moving fluid moving their property over there. So your blood is constantly moving, and the whatever nature set certain pressures, and now the pressure is increasing. So same way they keep on injuring these areas, and that converted into the collagen material, that prone for the bleeding, because that area becomes weak over there. And the one fine day, suddenly over the time period, and the suddenly, so sometime there may not be an immediate history of the high blood pressure when somebody is having a ischemic stroke. It's not the a physical injury immediately happens. The biological injuries happens, and one time fine day, nobody knows which area becomes so much vulnerable. Even 120 mmHg of the blood pressure can cause the hemorrhage over there. And people say blood pressure was completely controlled. It wasn't the problem. So it is not the acute kind of this thing over the days and years which causing. So this was the principle which I told you, the right angle, and this is the reason why basal ganglia hemorrhage happens. So lenticulostriate vessels, thalamostriate vessels, pontine perforator, and cerebellar vessels all are the reasonably right angles. That's why these are the classical. And sometimes you will find a parenchymal also, and these are the abnormal anatomy which can happen, like a tumor and metastatic, and sometimes amyloid angiopathies also. That can lead to the unusual location of the hypertensive. So I hope I am clear about that. And now the management. High blood pressure at presentation. The problem, this stroke is different from the ischemic stroke. Here, the more problem is the hematoma expansion. One is the hematoma expansion, and obviously surrounding areas also getting the ischemic insults over there because of the hyperperfusion. So if you keep the blood pressure high, then the hematoma expansion will happen. So decreased flow surrounding ICH is appropriate for corresponding. So now the question comes, if I decrease the blood pressure, then what will happen to the that autoregulation? So anybody can question me also, sir, you are saying the autoregulation is happening. So this blood pressure, how it can be possible? Ischemic stroke happen, then the autoregulation phenomena happening, but hemorrhagic, it doesn't happening to the surrounding tissue. It happens, but simultaneously the cerebral metabolic rate becomes so much low over there. So if you reduce the blood pressure, even that surrounding will not be harmed as much as the ischemic stroke is there, because they directly reduce perfusion over there. The surrounding tissue is not really getting so much hypoperfusion. So if you decrease, and their cerebral metabolic rate also decrease surrounding area, and therefore when you decrease the blood pressure in hemorrhagic stroke, your surrounding area of the brain will not be as much harmed due to the autoregulation phenomena as happens in the ischemic stroke. And that actually shown in the different PET and MRI studies. Cerebral blood flow autoregulation, this reason is preserved, and some enthusiastic people also, therefore I made a little bit question mark over there. They says still they are having some autoregulation, they allowed the perfusion to be maintained even the low blood pressure. So what is the final R statement here is acute lowering of blood pressure to 140 mmHg in less than 6 hours. When we say less than 6 hours, it's like a semi-emergency. You will not wait for the 6 hours. You start immediately, but try to achieve the within 6 hours. If earlier is the better. From 152 to 20 mmHg systolic is safe and help in the prevention of hematoma expansion. So hemorrhagic stroke, blood pressure in hemorrhagic stroke is a little bit different from. So initial goal is 160 to 90 mmHg in the first 1 to 2 hours. So that was a intracranial hemorrhage hematoma. Expansion restriction is the first priority, and later on, obviously, once the hematoma is static, then you allow the gradual fall in the blood pressure. SH is a little bit distinct over there. So these three things similar to each other, but blood pressure management is entirely different. Subarachnoid hemorrhage, what is the problem in the subarachnoid hemorrhage is, obviously there may be some anatomical problem, may not be a primarily hypertensive etiology. In ischemic stroke and the hemorrhagic stroke, we have seen the primarily hypertensive etiology. It may be hypertension is contributory over here, not the prime. And there is a list for risk factor of the rebleed, where the systolic blood pressure more than 160 mmHg is the one of the risk factor for the SH. So we have to address it. So mainly principle, what is the problem with what is the nuances when we deal with the hypertension in the presence of the subarachnoid hemorrhage? Especially we divide into the two segments. One, when SAH unsecured aneurysm. So when SH with the unsecured aneurysm, what I mean to say, aneurysmal bleed is there, but no intervention has been done yet to a coiling or clipping of this patient. Then the rebleeding chances is very, very high. So all the attention is to prevent the rebleed, and therefore you keep the systolic blood pressure less than 160 mmHg. When aneurysm is secured, your concern shift from rebleed to the vasospasm and delayed ischemic neurological deficits, DINDS, which we call it. Not go into the detail of this thing. This is not the chapter for, not the topic for discussion. But here your concern is a little bit different, and over the timeline that also important over there. So here you do not treat hypertension. Rather than the problem is there, you augment blood pressure and cardiac output in this. These are the two distinct entities. I hope I understood. Not again go into the very, this is the important from the SH point of view, which drug you should use, how is the interaction with the nimodipine also causes the low blood pressure, and how all these things will not go into detail. This is the crux over there. When aneurysm is not secured, you have to reduce the blood pressure till 160 systolic. Again, the further reduction caused the problem for the, because SH again the different problem over there. One is the rebleed and the surrounding area is actually getting the ischemia. So you have to balance both the things. Now things becomes a little bit easy further when we discuss about the press. Press is typically when press and hypertension, which we call is the hypertensive encephalopathy. Press is the more you can say pathological as well as the radiological, radio imaging kind of terms. But in clinically, if whatever we see the radiological associated with the hypertension, then we call it the hypertensive encephalopathy. For us, hypertensive encephalopathy in press is almost similar. So we manage in the same way. Subacute neurological signs and symptoms would be headache, ultrasensorium, seizures, and visual disturbances. I'll tell you why visual disturbance in the posterior circulation. Diagnosis primarily with the MRI by T2, flare, and diffusion weighted imaging, and they all shows a vasogenic edema, not the cytotoxic edema, vasogenic edema, because exudation and all these things. Initial slide, remember the same thing happens everywhere. That happens in the retinopathy, that happens with the kidney nephropathy. Same thing happens here in the posterior circulation, the exudation and all these things happens, constriction and finally hyperemia that causes this entity. Location actually make this entity in a specific way to manifest. Acute severe increase in the blood pressure causes endothelial injury, breakdown of the blood-brain barrier, and vasogenic cerebral edema. White matter. Now, this is the most important. People think, or why it happens in the certain area? Why posterior circulation? Why not in the anterior circulation? White matter is less tightly packed than the overlying cerebral cortex, thereby making it more vulnerable to the spread of edema. So wherever there is a not tight white matter is usually, that's what it is happening in the mostly in the white matter. Sympathetic fibers around arterioles in the anterior brain. It is thought this allows greater vasoconstriction and relative protection against the effect of severe hypertension. So they constrict more over there. When hypertension happens, if any organ is having a capacity to really vasoconstrict, it prevents from the hyperemia because the blood pressure causes a more flow over there, and it is not allowing, and therefore no pressure gradient. That's why the anterior part little bit impaired. And this is the classical just MRI I show you, posterior circulation, occipital kind of areas, and it can happen in the anterior circulation also. It's purely a probability over there how your anatomy is there. But most of the anatomy of the posterior circulation which favors this insults to happen, and therefore it happens in there only. Management plan, same acutely hypertensive emergency which you discussed, and last slide we'll discuss the how you can select over there. Acute coronary syndrome, this is important because here raised blood pressure can cause the acute coronary syndrome, and the acute coronary syndrome, the sympathetic activation. So here you really, if blood pressure is 200, 220, and thus you can see the EC changes, you have to act fast because that itself can reduce the coronary ischemia. Why happens? Pressure is high and vasoconstriction, those causes a stress to the myocardium, and that produces the ischemia. Oxygen consumption is increased by the increase in the heart rate, contractility, and wall stress. So wall stress primarily happens, and then in relation to the heart rate increases, all these things, they further reduce the oxygen supply. So beta blocker, I only emphasis over there. What beta blocker does? It decreases heart rate, contractility, and decreases blood pressure. Therefore, all these things problem happens, which causes the insult. If you select a one drug and addressing all these things, definitely it would be a drug of choice over there. So that is why beta blocker is drug of choice ACS with the hypertension, if it is not contraindicated otherwise. And evidence has also showed a beta blockers decreases mortality by 28 to 34% in the different studies, and decreases the reinfarction rate by 18% and cardiac arrest by 15%. So this is the reason why beta blocker is drug of choice. Regarding the ACE inhibitor, that increases the afterload and oxygen consumption, reduce mortality in patient with the heart failure and after myocardial infarction. But primarily, it is more for the heart failure. The infarction is your beta blocker. So therefore, ACE inhibitor should be given within 24 hours of MI patients with the EF less than 40% and heart failure. Acute heart failure, acute hypertension exists in the majority of patients presenting with the fresh pulmonary edema and is likely to be both the consequences and contributory. So both the things happen. So hypertension causes a more pulmonary edema, or heart failure causes a more hypertension initially. So NTG is here. And if you combine NTG with the loop diuretics, that is the class 1 regime for the heart failure, pulmonary edema, and hypertension. For this thing, this NTG vasodilator and coronary dilator loop diuretics to reduces ACE inhibitory for the chronic, not on the acute kind of this thing is. People use the clinidipine, that only calcium channel blocker, which actually give the favorable result in the heart failure. Otherwise, other calcium channel blocker, especially the amlodipine and nicotine, not at all should be used in the acute heart failure. Aortic dissection, it requires a little bit understanding over there. This is important graph. The blood pressure increases. So aortic dissection is there is an intimal tear in the large aorta. So you see, this is the blood pressure over the time period increase, and this is the rate of rise of blood pressure over the time. So you see the initial, obviously rate of rise is there and the high blood pressure, high pressure is maintained, then obviously there is no rate of rise remain and decreases, then the obviously rate of decay of the blood pressure. So in aortic dissection, not only the high blood pressure, your rate of rise of the blood pressure, that also important. So it's not the 200 by 100. Two patients is having a 200 by 100 and 200 by 100, but their rate of rise is more, then they will get a more harm in the aortic dissection. And every stroke, so there's a systolic pressure. So every stroke is happening. So if you combine rate of rise is high and multiple times. So if you combine with the rate of rise is very high and the heart rate is very high, that would be a very dangerous combination in the aortic dissection. And that is the reason our aim is aortic dissection to limit the propagation of intimal tear, and beta blocker, that is the reason it decreases the force of contraction and heart rate, both the things. So please mute if somebody
Please
is.
mute everybody. Don't interrupt, please.
We are getting background noise. So here, very, very important for all the student to understand, beta blocker is the indication for the aortic dissection. One, it decreases the force of contraction, thereby the rate of rise of blood pressure, which we commonly known as a dP by dt, differential pressure to differential time to pulse, and heart rate also. So just heart rate lowering agent will not sufficient, and simultaneously, if beta blocker is contraindicated, then you can give the calcium channel blocker, which is a negative inotropic and chronotropic. Though diltiazem and verapamil can be used, but not the replacement of the beta blocker as such. Pure vasodilatation, not at all. Pure vasodilatation, not at all. Must not use the NTG, SNP as a upfront in the aortic dissection. Almost it is a serious deficiency of your management if you are using the NTG in the aortic dissection. It's not the blood pressure only, as I told you. It's a shear force, you have to reduce it. And what happened if you reduce the blood pressure by number little bit, but reflex tachycardia causing more harm than the benefit. Once you give the adequate beta blockade and you feel the blood pressure is not still in the control, heart rate is low, then you can use the SLP. And target heart rate is less than 60, and the systolic blood pressure, obviously you can go lower in the
Shwetanjali, please mute yourself. Shwetanjali.
pregnancy induced or associated hypertension. One or two slides for the last, and then we'll have one or two questions. Here we need to understand pregnant lady presented to the ICU with the blood pressure. What are the possibility? Either this patient is having a pre-existing hypertension. This usually starts before pregnancy or before 20 week of gestational and last more than 6 weeks postpartum with the proteinuria. They may be pre-existing. Gestational diabetes by definition starts after 20 weeks of gestational and never last more than 6 weeks of postpartum. There may be a possibility pre-existing hypertension plus superimposed gestational hypertension with proteinuria. There may be possibility. Preeclampsia can happen. Preeclampsia and difference with the gestational hypertension, those gestational hypertension with proteinuria, then you label it as a preeclampsia. But preeclampsia is also with the vasoconstriction, endothelial dysfunction, platelet aggregation, and increased coagulation. So remember right from the beginning of the talk, which kind of hypertensive we are talking about. This preeclampsia fulfill all the requirement of these things. So once you enter into the preeclampsia, all the principle which we initially learned in our talk will be applicable. And eclampsia is the more severe form where you can really see the CNS manifestation in terms of the seizure, headache, visual disturbances, abdomen pain, nausea, vomiting, and of course renal failure. So these are the spectrum of the blood pressures, high blood pressure with the pregnant lady. Mild hypertension, as I told you, will not discuss mild hypertension otherwise, but here just I need to mention because anyway this pregnant lady come into the ICU. Mild hypertensive patient not come into the ICU for the management, but the patient who is having pregnant lady who is having a little bit higher blood pressure, they usually come to the ICU in the at least in the corporate hospitals. So drug treatment, only drug treatment. I'll not say treatment. Treatment, general measure, and all these things you will do. The specific antihypertensive management once it crosses the 150/95, all women. But if it is a gestational, then you start treating it little bit early. So once it is crosses, irrespective whether gestational pre-existing, you have to treat it with the medication. But if it is a gestational diabetes, gestational hypertensive, then the more than 140/90 required a treatment. Drug treatment in the hypertensive with the subclinical hypertensive mediated organ injury at any time during pregnancy. So if you see this organ damage, then you have to treat it. And first choice here is methyl dopa, beta blocker, labetalol, dipyridine calcium channel blocker. These are the nifedipine, not the diltiazem and verapamil. So DHCCB is a nifedipine, not in the capsular form. So previously, many years back, the capsular gelatinous capsule was there. No, this is the now we are using a sustained release nifedipine that can be used, and nicardipine. Contraindicated drugs you must know: renin-angiotensin system blockers, AC inhibitor, ARB, direct renin inhibitors. Due to adverse fetal and neonatal outcome, we don't give it. If this is not an issue, due to some reason, the fetus and compromise all this thing, then only otherwise. Now the severe hypertension, which is our basic discussion of today's talk. So this pregnant lady entered into the severe hypertension. Here we labeled it as a more than 170/110. Generally, we give the definition more than 180/110. Otherwise, patients, but this is a more. This number is for your MCQs and the theoretical. In clinical practice, it's not just a number. Like in general hypertensive emergencies, if the things you are seeing at the value of 170, then you will act over there. So these are the numbers. Obviously, you have to remember when you are preparing for the exam. Treatment with the intravenous labetalol when the severe alternative intravenous nicardipine, esmolol, hydralazine, and urapidil. So now in India, we are having a labetalol only available, hydralazine. Previously, it was there, but now it is withdrawn from the Indian market. Esmolol we are having, nicardipine we are not having freely available in India. Oral methyldopaline or obviously nifedipine or nicardipine can be used. Magnesium can be added hypertensive crisis to prevent eclampsia. So in this situation, once we reach to this situation, apart from classical antihypertensive, we can add, well, not we can, we must add magnesium. And what pulmonary edema happens, then the nitroglycerin can be used. And sodium nitroprusside should be avoided due to danger of fetal cyanide poisoning with prolonged treatment. So if you land up with this severe hypertension, pulmonary edema, then NTG should be used and SNP should be avoided. Last specific condition, perioperative hypertension, just 2 or 3 facts over there, nothing much difference. The basic principle here remains same like antihypertensive, but the few things which this is entity, you just aware about that. Sometime it comes into the ICU and everybody is asking why happened, hypertension happened. This is a known entity, hypertension, perioperative hypertension. So preoperative hypertension thought to be a perioperative risk for the mortality, major morbidity, prolonged length of stay and readmission, intraoperative blood pressure elevation of greater than 20 centimeter of baseline blood pressure are considered to be a hypertensive emergency. Risk factor, vascular surgery, neurosurgery, intrathoracic surgery, abdominal surgery. Hypertension occurs in the setting of craniotomy more often than with any other type of surgery. And this is the important trick over there. The craniotomy, severe hypertension occurring intraoperatively or during the first 12 postoperative hours have been associated with the higher risk of intracranial hemorrhage that complicate the craniotomy. So here you have to act fast over there. Just I summarize all these things according to the guideline. This is a European Society guideline, one of the most latest, you can say, 2018 guideline, where I summarize mild hypertension with malignant hypertension without acute renal failure. You have to treat obviously over the several hours and reduce MAP by 20-25%, labetalol, nicardipine, and alternative you can see in your screen. Hypertensive encephalopathy immediately, and MAP reduced by 20-25%. Drug, labetalol, nicardipine. Acute coronary syndrome immediately, less than 140 mmHg systolic. Here now you can see the drug has changed. Everywhere you see labetalol, now here is the nitroglycerin little bit prior over the labetalol. Acute cardiogenic pulmonary edema. Now here you will not see the labetalol. Beta blocker should not be given. So nitroprusside, nitroglycerin with loop diuretics. Acute aortic dissection immediately, less than 120. This is the guideline. I would say lesser is the better. Not to the tune of the 80 systolic. If you can keep 110, nothing like that, can go for that. And heart rate less than 60. Here now, esmolol, not even the labetalol, pure beta blocker, and then later on nitroprusside after beta blocker and the eclampsia and the severe eclampsia, preeclampsia. So you can see the immediately, but numbers you can just remember on you can save your screenshot, or it is available, freely available in the same game. So sometime it is asked in the Viva exactly number. The principle is this: you have to treat immediately, and drug is the labetalol. Similarly, this is the from the guideline. Yeah, this is more latest, 2020. International Society of Hypertension, Global Hypertension. Almost same, but the previous guideline actually did not mention stroke part. So here I'll concentrate on stroke. Acute ischemic stroke, 1 hour you have to reduce, within 1 hour you have to reduce by the 15%. Here you remember the, here 15% important, not further. And remember, once you decided, when you decide based upon this thing is, if blood pressure more than 220 or diastolic more than 120, labetalol everywhere you will find, except some condition which we already discussed. Hemorrhagic stroke is a different. So you systolic blood pressure more than 130 and less than 180, labetalol, and rest of the things we already discussed. So this is a comprehensive slide. I'm not sure. Is it visible, Dr. Tapesh? It is visible in
Yeah,
your.
it is okay, but you have to strain a little, very detailed, small.
So aim is not to really read it out. If it is visible, then the student can just take the
Yeah, they
scan.
can review it when we put it up the video. Yeah.
Yeah. So we pause just for the 3-4 seconds so that one can take the snapshot over there. Whatever we discuss is a comprehensive one table, all the different secondary conditions over. Okay. Now we move on to the our last question. What is the best treatment for cocaine? I would expect everybody to participate. This is the last question. Cocaine-induced hypertension. Please respond. Beta blocker, alpha blocker, benzodiazepines, naloxone.
I think this is a difficult question for them.
So the answer here is benzodiazepines. Not the, though alpha blocker can be given, but once the interesting fact related to the cocaine poisoning, the benzodiazepine is the drug of choice for the cocaine-induced hypertension. Use of beta blocker is dangerous. Use of beta blocker is unopposed alpha stimulation causing the blood pressure. As I told you, the cocaine-induced hypertension is entirely different from the basal ganglia bleed is having a hypertension. There, the hypertension present over the days to years together. This probably a point event over here. So beta blocker is contraindicated. Alpha blocker can be given. So what I actually thought people may confuse over the alpha blocker and benzodiazepines. If benzodiazepines contraindicate already given, the alpha blocker can be given. Both can be given. But once the drug of choice is asked, then benzodiazepine is the drug of choice. So with this, we finally reach to a summary of our talk. The summary is hypertensive crisis is a medical emergency, should get immediate attention. Focus should be on associated pathologies and or hypertensive mediated organ damage. General measures to manage all type of hypertensive emergencies are common, whereas control of hypertension varies among specific clinical conditions. Goal and targets must be set and constantly be followed. Do not hesitate to redefine goal and targets in emerging new situations. And be thoroughly aware about the pharmacology of antihypertensive drugs being used. This last point will be taken by the Dr. Neha. So with this, I thank you, Dr. Tapesh, to give me opportunity to really interact with all the young colleagues. Thank you.
Thank you, Dr. Jinder Sharma, sir. A very nice and elaborate talk on hypertension in the ICU, explaining the concepts also. So please stop the share screen so that Dr. Neha can come on. So the next session, Dr. Neha.
Yes, I'm going to share the screen.
The session will be taken by Dr. Neha Arora. She is a senior consultant in critical care in Paras Hospital, Gurgaon, and she'll be talking on the pharmacology of antihypertensive drugs.
Good evening, everyone. Today we are going to discuss, after the comprehensive talk of Dr. Jitendra regarding the antihypertensive drugs that we are using in the ICU. So first, just a little bit of the normal regulation of blood pressure. According to the hydraulic equation, as the blood pressure in our body is regulated by the precapillary arterioles, venules and all, that blood pressure is mainly, the outcome is dependent upon the cardiac output and the peripheral vascular resistance, which is dependent on the precapillary and postcapillary arterioles and venules. So in our body, mainly blood pressure is maintained by the 4 factors. First, the peripheral vascular resistance, that they're having the autoregulations with the different at 3 points. Another is the kidney with the renin-angiotensin system. Another, the baroreflexes mediated by the autonomic nerves, and the local release of the vasoactive substances. Now, what's the pre-hypertension? What are the stages of the hypertension before we are going for the antihypertensives? The guidelines have changed from the previous one to the new ones, having within a normal of less than 120 to 80 is the normal. The pre-hypertension is the 120 to 139 or 80 to 89. And the next is the stage 1 and stage 2 with the respective BPs of 140 to 159 and diastolic BP of 90 to 99, and the stage 2 hypertension of more than 160 or more than 100. So as sir has already elaborated very nicely about the what is the emergency and what is the urgency. If there is an involvement of the target organ damage is there along with the BP elevation, it's called an emergency. And mostly in the ICUs or in the critical areas, we are dealing with these kind of patients where the patients are coming with a target organ damage, like having the MI, arrhythmias, failures, the renal diseases, AKIs and all. So these kind of patients we are dealing with in the critical area part. So mostly the patients that we are dealing is having the emergency. Some patients are having the urgency also, where there is a likely to go to the target organ damage, but still it's not there. Like the patient having chronic diseases, like renal failures, cardiac chronic, but they are compensated. But if that urgency can become an emergency in these kinds of these patients also we have to manage very aggressively as along with the emergency. So as sir has told, the target organ disease may be the cardiac, maybe the cerebrovascular having the intracerebral bleed or stroke, or renal with the hematuria, proteinuria, azotemia, or the retinopathy features, as sir has already explained in detail. The pathophysiology, I think sir has already discussed, we are not going. The treatment goal regarding the what is the BP target of reducing in the ICU or in the emergency situations is not to go to the normal, because as sir has told in the stroke regarding penumbra, ICH, hematoma expansion, everything. So generalized goal is decrease the mean arterial pressure by 20 to 25% only within the 1 hour, followed by decreasing within the next 2 to 6 hours of 160 to 100. We are not targeting the normal blood pressure of 140 and all, because the auto regulation or the further things the organ perfusion is also necessary with the increased blood pressures. So more gradual reduction maybe over the next over 1 to 2 days will be our target. So what are the drugs that we can use as an antihypertensives to reduce there are various categories, various families of drugs that we are using. The first is the diuretics with the thiazides, the loop diuretics, the potassium sparing diuretics, the ACE inhibitors. Each and other family have their own pros and cons. That is a mechanism that depends upon what antihypertensive agent you will use in the specific patient is individualized, depending upon what is the comorbidity of the patient and what is the failure system. If the patient is having cardiac failure or is having the renal failure, some drugs we can use in the renal failure is preferably, some is used in the cardiac failure. So different categories that at that point, the antihypertensive agents that we as an intensivist are using is very important, because we should know what is the side effects of each antihypertensives, and aggressively we have to decrease the blood pressure in the initial stage to prevent the further organ damage. So early onset of action of the antihypertensives is necessary in ICU. After that, we can shift over to the oral antihypertensives when the BP is stabilized and we are find that it's okay, the further organ damage is not progressing. So we can later on switch over to the oral antihypertensives. So what are the various families of antihypertensives? The diuretics, the ACE inhibitors, the angiotensin receptor blockers, beta blockers, calcium channel blockers, alpha and beta energetic blockers, that we are having the option of labetalol or carvedilol, alpha 1 blockers, prazosin, terazosin, central sympatholytics, vasodilators, arterial, we're having the option of hydralazine, minoxidil, and diazoxide, arterial and venous with the sodium nitroprusides. There are some centrally acting reserpine ganglion blockers. So that's the important, that where we should know before choosing any specific antihypertensives, what are the receptors present at what area and which antihypertensives we are using, that we have targeted on that part. Like if we are thinking of there's certain, like if kidney is the issue or something is there, we can't use the ACE inhibitors, we have to go for the other. If there are some heart related issues, the beta blockers we can use, but in some conditions beta blockers can't be used. So the site of action and their mechanism, and we have to see where the receptors are there is very important while choosing any of the antihypertensive drugs. So at heart, beta 1 receptors, propranolol and other beta blockers, calcium channel blockers causing muscle vasodilatation, alpha blockers like prazosin we can use, they are having effect. And 82 receptors also is 81 receptor blockers like losartan and other are also there. In kidney, we can use the thiazides, the loop diuretics if the patient is in fluid overload. So next point is the emergency. Like we are only dealing in ICU with the emergency conditions. So basically, emergency, as sir has told already, the BP on the high with the target organ damage. So what are the drugs we can use as a first line of management in the ICU? Like mostly patients are either post-op or the stroke or the ICH bleeds. They're not very conscious to take the tablets. So the first line of management is the intravenous drugs that we can use to them. So next question is which intravenous drug to use and in what condition. So the variety of medications are there. That is, we are having vasodilators like nitroglycerin, nitroprusides, the nicardipine and clevidipine are the calcium channel blockers which are coming in IV, labetalol, the alpha beta blockers. In some cases, not usually, we are using these as hydralazine, and we are other drugs also. So what is the mechanism of action of the drug, and how and what rate we are using, and what is the side effect that we have to keep in mind while using any drug? First is the sodium nitroprusside. It releases the nitric oxide, which through the cyclic GMP, causing the relaxation of the smooth muscles and the vessels, causing vasodilatation. So it's a nitric oxide. It's act both at the arterial and the venous dilator, mostly used in the hypertension crisis. Contraindicated, basically it's in the high output cardiac failure, because it's causing, as it is effective in a lot of cases where we need immediate control of the, like in stroke or in other cases where heart rate is on the lower side, and the labetalol we can't use. Even the first drug we are mostly using in all the ICUs, the labetalol for the stroke. But in some cases where the patient is already on the beta blockers and he is not having the heart rate of the around 650 to 60, in that case sodium nitroprusside we can use. But there is the major side effect, it's the cyanide toxicity that we have to keep in mind, and what dose. So for short duration, we can use the nitric oxide, but not for the long. More than 48 hours, we are not using because of the thiocyanate toxicity, and may use, then for that, we have to use the thiosulfate and another. So what are we have to give, then we have to keep in mind the features of the cyanide toxicity also, like tachycardia, acidosis, or the altered sensorium, hyperreflexia. This should also be monitored in the patients giving the sodium nitroprusside. Next drug is the labetalol. It's, as sir also told, it's the alpha beta blocker with the beta is more, beta to alpha ratio of 7:1. It's affecting both on the alpha receptors and the beta receptors. So it's very good drug if we are using in the like stroke patients or the other, where we use both. Heart rate is on the high side, we want to lower it. The beta blockers are having effect on that, and the alpha also causing the decreasing the peripheral vascular resistance with the alpha receptors. And it's also having a further immediately onset of action within 2 to 5 minutes with the duration of till 66 hours. We can give initially the boluses of 20 mg, but the maximum dose after infusion also we have to calculate. This should not go beyond 300 milligram. Also we can use in the pregnancy patients also. Labetalol is the drug of choice, like mostly in the PIH patients who are coming to the ICU, we are using this drug. But you should know where to avoid it. Mostly beta blockers is there. So the contraindication of beta blockers should definitely come into mind, like with patient having hypersensitivity of the airways, with already having heart rate on the lower sides or the heart blocks. In that condition, we can't use the labetalol. NTG, initially definitely very good drug for the heart issues. The patient is having pulmonary edema, specifically pulmonary edema with normal ejection fraction. If the patient is, these kind of patients is there, the nitroglycerin is basically in the lower dose, it acts as a vasodilator. But if you increase the further dose, it will act as an arterial dilator also. So causing both the decrease in the preload and decrease in the afterload work. But the main issue with the nitroglycerin is the tachyphylaxis. If you will use it for more than 48 hours, it is not that helpful because the receptors will get desensitized and it will not having much effect. Esmolol is one of the best drug that we can use even in the post-operative or the aortic dissection patients, because it is having very short action and the duration is also very long. So you can titrate the dose according to the target BP, and because of it's not dependent upon the hepatic or renal function, you can give in the liver failures or the kidney failures. You can give that. There is no issues of because it's very short acting. You can titrate, put the arterial line, start the esmolol, and then you can use it and titrate it accordingly to the BP. Phenoldipan is a dopamine agonist, not available in the India. So, but definitely for the students, we have kept this slide. It's a basically primarily dilator, arterial dilator. Kidney it will increase the further renal blood flow, causing more of the nitriuresis. The dose is of 0.1 mics per kg per minute and titrated according to the list. Hydralazine, previously a very common drug to use, but nowadays we are not using that because there is a reflex tachycardia. It's a direct arterial dilator which is used in the pregnancy or eclampsia patients, given in the doses of we can't use it in the intravenous dose as an infusion, but using as a dose of 10 mg after every hour to the maximum of 20 mg. But the reflex tachycardia is the main issue that further increase the heart rate and further increase the oxygen requirement in a cardiac patients. So this drug is not that used commonly these days. Calcium channel blockers, definitely according to the patient. If the patient is having diastolic dysfunctions, the patient is aged patients, you can use, we have the option of IV. The availability is an issue, but it is a good drug. If you can give an infusion with the 5 mg starting, the maximum you can go to the 15 mg per hour. And clevidipine also is a good drug that reduces BP without affecting the cardiac filling pressures or reflex tachycardia, as the problem with the other calcium channel blockers, like they are having negative chronotropy, inotropy effects. This drug is good. Among the other intravenous medications, enalaprilat with the only ACE inhibitors that we can use in an intravenous, and that also we can use every 6th hourly, not as an infusion. There is a parenteral ACE inhibitors that we are having the option, but kidney diseases, hyperkalemia, that limited but it's a very good drug for the heart failure patients, especially in the chronic heart failure patients, without having any renal dysfunctions. Trimethophan is a non-depolarizer ganglionic that is basically used in the aortic dissection. Pentolamine in the emergency crisis, hypertensive crisis conditions like in the pheochromocytoma, there where we need the alpha blockade. Ideally, we need both the alpha beta blockade, but if there is no option, we have the alpha blockade. It is a very good drug in the pheochromocytoma, where surge of catecholamines is there, causing increased BP and heart rate. So these are the intravenous agents that as a critical care intensivist, we need to use immediately to reduce the blood pressures. Later on, we can switch over to the oral antihypertensives as the patient is giving us the time. The main crisis condition, like as Sir told, is a stroke, like patient is going for the thrombolysis, the stroke, and we have to immediately reduce the blood pressure. In that, labetalol is the drug of choice that we are using these days, or nitroprusside we can use. The another thing for the heart patients, we are preferably going for the nitroglycerin. And for the other, according to the condition of the patient, the comorbidities of the patient, we can use further. So the other class of the drugs that we are using is, now we are discussing in the detail, how these drugs act, what is the side effects, at what is their site of mechanism, at what point, what receptors they are acting. So I'm starting first with the beta blockers that we mostly use in the ICUs or in the cardiac CCUs. We use a lot of these drugs. Mainly what the mechanism is the decreasing the heart rate and the output and stroke volume, because the beta-1 receptors is mainly at the heart. Beta-2 receptors are only in the kidneys. So beta blockers, they have effect on both the sides. On the beta-1, if it reduces the heart rate, it reduces the contractility, reduces the oxygen demand of the patient, of the cardiac muscles. And in the kidney, it releases renin, which increases it stops the release of the renin, causing further peripheral vasodilatation. A little effect of also beta blockers is there. So it decreases contraction and cardiac output, reducing the oxygen demand of the cardiac muscles, decreases renin secretion, which will further lead to aldosterone secretion and vasoconstriction. So that activity is also inhibited by the beta blockers, and it having a superadditive effect of the central sympathetic activity also, it will decrease by the presynaptic beta-2 effects. So what are the cardioselective classification? Non-selective, which are having both beta-1 and beta-2. They are the nadolol, timolol, sotalol. But we are basically focusing on the cardioselective in the ICUs, like metoprolol, nebivolol, bitaxolol, atenolol. There are some alpha beta combination is also there that is used like labetalol or carvedilol. Some with having the intrinsic sympathomimetic activity, some are not having the intrinsic activity. But main that we are using in the ICU is the metoprolol, bisoprolol, carvedilol that are the having mortality benefit even in the heart failure with reduced ejection fractions. Next is the alpha adrenergic blockers, the prazosin we are using. It basically block the alpha 1 adrenergic receptors on the arterioles, reducing the arterial resistance, and the peripheral afterload is reduced. It reflects increase in the heart rate and plasma renin activity. So sometimes we are combining this prazosin with the beta blockers to prevent the further increase in the heart activity. Posterior hypotension may occur because of the immediately arterial resistance reduced and afterload reduction. So posterior hypotension can occur with this. Hydralazine, as we have already discussed, it arterial smooth muscle relaxation. It has no effect on the venous smooth muscle. It's mainly effective on the arterial. It's mainly causing the release of the nitric oxide which are present on the arterial smooth muscles, which reflects increase in the heart rate, cardiac output. So not used these days a lot. Calcium channel blockers, they can affect. There are 3 type of voltage gated calcium channels like L type, T type, and N type. In that, L type is basically inhibited by the calcium channel blockers, which decreases the sarcoplasmic reticular contraction, and muscle myocyte contraction is inhibited, causing the sarcoplasmic because of the combination of that, which causes the relaxation of the muscles, causing vasodilatation further. Where the classification of calcium channel, there are 3 families, 3 subgroups: phenylalkylamines, benzothiazepines, and dihydroprins. They all having negative chronotropic, inotropic activity. So we have to specify in which kind of patients we need these kind of things. So basically block the L-type channels, which cause smooth muscle relaxations and having the vasodilatory reaction. The advantage of calcium channel blockers, like over diuretic, is having nothing like dizziness, fatigue, or decreased output as compared to the thiazides. It does not compromise the hemodynamics. It's not having any sedation effect. Can be given to asthma, angina, and PVD patients. But the main effect is because in heart patients, we have to very precisely, we have to see the patient and give because of the negative chrono-inotropic effect of these drugs. In cardiac patients, we are not using much these calcium channel blockers. So amlodipine, nimodipine in the SCH also is having the vasospasm, vasodilator effect. We can give nimodipine in these cases. Another are the ACE inhibitors. Then what's the mechanism of the ACE inhibitors? As we have all know, it's the angiotensinogen plasma alpha-2 globulin is released, on which renin acts, and it is converted through the decapeptide angiotensin 1, which further from conversion of angiotensin 1 to 2, the ACE inhibitor is having the role which blocks its conversion from angiotensin 1 to 2, because angiotensin 2 is the main vasoconstrictor that is present in our body, that is causing vasoconstriction, sodium and water retention, and further aldosterone secretion. So this angiotensin 2 conversion is inhibited by the ACE inhibitors, causing the vasodilatation. And these ACE inhibitors are very good in the cardiac patients. Basically, even in the chronic heart failure patients also, and in the acute failures, if the patient is having low cardiac output, the ACE inhibitors is the very good action. From angiotensin 2, when it's converted to angiotensin 3, here the angiotensin blockers is having the role. It will prevent the act on the receptors of the angiotensin and blocks its activity. So it's receptor blockers. ACE inhibitors are the conversion inhibitors from angiotensin 1. So what's the difference between the two that we will discuss further? The ACE inhibitors are recommended as first-line treatment of hypertension, mainly the cardiac patient with the history of diabetes, the stroke, the heart failure, myocardial infarction, or in the chronic kidney disease. These are the very good effect in this kind of patients. As we have already discussed, decrease the angiotensin 2 and increase the bradykinin levels. The increase in the bradykinin levels cause further side effects of the ACE inhibitors that we will discuss further. By reducing the circulating angiotensin 2 levels, ACE inhibitors also decrease the secretion of the aldosterone, which further decrease the sodium and water retention. ACE inhibitors also reduce cardiac preload and afterload. So it's very good drug for the cardiac patients, because it will have effect on the remodeling, on the preload, on the afterload, especially with the cardiac patients with the diabetes, it's the first line of treatment. So what are the other ACE inhibitors? The captopril, enalapril, lisinopril, fosinopril, perindopril, ramipril. But in the ICU, if your patient is coming in the crisis, we have as an IV drug preference of only enalapril. Among these, we are having a lot of people are using telmisartan, enalaprilat, or captopril these days. But they are all the oral drugs are there. There is no IV drugs of the ACE inhibitors in these kind of patients. Basically, as we have discussed, used in congestive heart failures, in the myocardial infarction, or in the prophylaxis in which the high cardiovascular risk subjects, like the patients with diabetes, the patients with stroke, the patients with all these other kind of patients, we are using ACE inhibitors. That are the ACE inhibitors that prevents the angiotensin 2 production. The angiotensin antagonist, like we are using now a lot these days, the Vimada or the valsartan, telmisartan, losartan, their pharmacological effects are the same, but it do not increase the bradykinin levels as the inhibitors. So as compared to the action of both is the same, but the side effects of these angiotensin antagonists is reduced as compared to the ACE inhibitors because of the bradykinin levels. It's used as a first line drugs in these kind of like oral. If you are taking first line of treatment is these in the diabetes, heart failure, or CKD patients. Next family is the thiazide diuretics, but these we are not using as in the only in the cardiac patients with the pulmonary edema who are coming to the ICU. We are using diuretics, but it's more of a OPD class patients who are coming for the first day with diagnosed with the hypertension, and then we have to use the thiazide diuretics. That is the first, that patients is quite very effective with this drug. Basically, thiazides are the hydrochlorothiazide and chlorthalidone, which lower pressure increased by the increased excretion of the sodium and water, and causing reduced retention of these sodium and water in the body, which further decrease the blood volume, which further decrease the cardiac output and causing decrease in the blood pressure. And it also has some effect in decreasing the peripheral vascular resistance also. That is quite effective in the reducing the afterload of the patients. Loop diuretics that we are using, it causes inhibition of the sodium transport at the collecting tubules, like loop diuretics, loop of Henle is affecting. So the potassium sparing diuretics is also these days we are using in the cardiac patients along with the beta blockers and the ACE inhibitors. We combine these potassium sparing diuretics, and it further having a beneficial effects in the patient, because it reduces further potassium loss in the urine as the previous loop diuretics or other they cause. Aldosterone antagonists, spironolactone and the eplerenone are these days very effective in the cardiac patients for diminishing the cardiac remodeling also, that mostly occurs in the heart failure patients. Another drug we are using these days is the minoxidil, but this is mostly used in the resistance hypertension. We have using already 2 to 3 drugs. We have already started the ACE inhibitors, the diuretics, the beta blockers, but even that pressure is not controlled. Then minoxidil used is that. Basically, it's a potassium channel opener. It converted in liver to active form. It mostly produces the arterial vasodilatation, which causes further increase in the cardiac output. It dilates also the renal artery. Net effect depends upon the hypotension and extent of dilatation. So minoxidil previously used for the hair growth. Now it's also being used as a antihypertensive for the resistance cases. Clonidine. Clonidine is a central sympatholytic which stimulates the alpha-2 receptors of the brain and causes reduce of the central sympathetic outflow, which further decreases the concentration of the noradrenaline and decreases the sympathetic outflow, and then decreasing further the blood pressure of the patient. But it's having the side effect of the sedation. So in ICUs, chronic kidney patients, we can use a little bit of this because it's having very good control of the blood pressure. But in ICU, a little bit with a pinch of salt, because already like stroke patients, we have to see the GCS and all, sedation and further things we have to avoid. So in that cases, we can't use the clonidine. So drugs that to be avoided for the treatment of hypertension associated with some specific. Till now, we have discussed what is the line of treatment in all the like diabetic patients or the cardiac patients or the where we have to use the which family of drug. But some drugs to be avoided in specific comorbidities or diseases of the patient that we can't use that. In pregnancy, ACE inhibitors we can't use because it are having fetal side effects. ACE inhibitors can cause GERD, very dry cough, agranulocytosis, kidney damage. But main in pregnancy, it causes fetopathic effects, so it's not using. Diuretics also we are not using in pregnancy because it decreases the intravascular volume that of the pregnant female, that is having effect on the organ perfusion. So diuretics also not used. Mostly in pregnancy, as sir has told, we are using methyl dopa, we are using hydralazine, we are using these kind of antihypertensives with the magnesium, not this ACE inhibitors. Diabetes also, the first line of treatment is the ACE inhibitors. If the patient is not having any renal failure, any other features, then in that we are using ACE inhibitors. But diuretics, as already we know, it heavy diuretics can also, like the thiazide diuretics can cause hyperglycemia. So in diabetic patients, we used to avoid these kind of things. Asthma, we avoid beta blockers because of the hypersensitivity of the airway. Peripheral vascular disease, also the beta receptors causing autoregulation of the vessels. In that, the vasodilatation we need and the beta blockers we should not use. In chronic heart failure, because of the negative chronotropic and inotropic effect, calcium channel blockers can't be used in these kind of patients. So whatever the antihypertensives we are using, first is diagnose the hypertension, the staging, whatever stage of the hypertension is there. But from the main critical point of view, we have to use in the crisis condition or in the emergency, we have to use the intravenous medications, knowing what is the dosage and in what kind of patient we have to use and what are the contraindication of the antihypertensive agents, that we should not use these drugs in specific kind of the patients. So that thing is very important as an intensivist point of view. So I'm just finishing. Thank you, Tapesh sir and Jitendra sir for giving me this opportunity to discuss these things.
Thank you, Dr. Neha. Very nice of you to present the pharmacology of antihypertensive drugs. So one more question which students often ask, either you can answer or Dr. Jitendra can answer, is what drugs can we use if there's hypertension with CNS pathology? So if you want to answer, or Dr. Jitendra, are you there?
Yeah.
So this is a common question from the students, with intracranial pathology, what drugs to use?
So in CNS pathology, we have discussed in detail. Mainly, labetalol is the drug of choice. The question main comes whether you really want to treat or not. That is the main our contention to really decide about the intensivist. So three answer must be given: whether it is really treatment is required or not. Second is how faster we can go for, and what is the target. These are the three things needs to be decided. Now that comes to the selection of drug. Selection of drug depends upon the so many factors. This is a generalized view. Say, for example, the labetalol is the commonly used. Now the question comes: the individual patient who is having a contraindication to the labetalol, then the problem arises. So every time will not be a one answer for all the problems. Per se, CNS, because the CNS in origin is requires all type of the blockade, beta blocker, alpha blocker, and even the ganglion blocker. So that labetalol is a, you can say, primarily drug which we can use over.
Yeah, so I think it mainly relates to the ICT. If the ICT is raised, then you have to go for labetalol because it does not raise the ICT. But if the ICT is normal, then you can use the other drugs also. So that is the main point, because they don't increase the ICT.
But again, basic question again will remain whether you really want antihypertensive or not. Say, for example, if if the blood pressure is raised because of the ICP, then you have to manage the ICP. If blood pressure is raised because of it is required ischemic stroke, probably the nature actually given to the increase the pressure to maintain the ischemic zone to be perfused, then probably treating the number may be wrong things to do in that situation.
Yes, that is true. Agreed. Whether you have to treat or not to treat has to be also taken into consideration. So I think there are no more questions from the audience. I think with that we close. I thank Dr. Jitendra Sharma sir and Dr. Neha Arora ma'am. Thank you so much, everybody. Till the next session. See you. Thank you.
Thank you.
Thank you, sir.